Morgan. Sorry. I'm Ashley Morgan. I'm the director of the Substance Use Deflection Initiative, and we're housed in the Criminal Justice Coordinating Center of Excellence at NEOMED. I am a licensed professional clinical counselor with a supervising designation. I'm also a licensed independent chemical dependency counselor. So my background, I've spent the past 20 years working in substance use and mental health across residential treatment, intensive outpatient care, college counseling settings, research. And in my current role, I help to lead statewide training and technical assistance and help coordinate efforts to strengthen deflection and pre-arrest diversion programs across Ohio. And I'll let Amari introduce herself.
And my name is Amari McGowan. I'm the program coordinator for the Substance Use Deflection Initiative, and I'm just going to keep it brief and leave it at that.
Thanks, Amari. So each September, we recognize both Suicide Prevention Month and Recovery Month. It's a time to raise awareness and reduce stigma and connect people with resources that really can save lives, while also celebrating individuals in recovery. Because we see that substance use and mental health challenges are so often intertwined and both are really significant risk factors for suicide, we felt that it was important in today's presentation to not just focus on harm reduction, but take a little time to look at the connection between suicide and substance use and where harm reduction comes in. So we want to understand the intersection of substance use and suicide, and we can see that there are many ways that it's intertwined. There's a lot of overlapping risk factors and compounding factors. Overall, people with substance use disorder are 10 to 14 times more likely to die by suicide than individuals in the general population. And while all substances elevate suicide risk, alcohol and opioids stand out as especially critical. When we look closely, alcohol and opioids are the two most common substances we see in individuals who die by suicide. We see alcohol in approximately 22% of deaths and opioids in 20%. And for alcohol, there's a couple of layers. First, there's this acute intoxication that 24 hours after drinking is associated with a sevenfold increase in suicidal behavior. And then the second is alcohol use disorder, which carries a tenfold higher suicide risk. And it's the second most common psychiatric diagnosis in completed suicides. With opioids, the picture's just as serious. People with opioid use disorder are 14 times more likely to die by suicide. And the lifetime suicide attempt rates range from anywhere from 17% to 48%, depending on what literature you're looking at. And beyond the substances themselves, we have to remember there are compounding life factors, things like trauma and emotional distress or physical consequences of use. So the point here is that substance use and suicide, they don't exist in silos. They're intertwined in complex and overlapping ways, and it's critical that we use integrated approaches to care and harm reduction. You can go to the next slide, Amari. So looking at how suicide and substance use overlap, why it's so strong. First, there's, as I said before, a lot of risk factors, things like trauma, chronic pain, depression, stigma, isolation, economic hardship, hopelessness. These are all drivers, both of substance use and of suicide risk. There's this motivation to escape painful internal states. And many people will turn to substances to soothe and escape suffering. But when suffering becomes too overwhelming, suicide might be perceived as the only way out for some individuals. Next slide. And we see physiological states that overlap as well. So intoxication itself plays a role. It lowers inhibition and it fuels impulsivity, promotes risk-taking. Substances like alcohol can really increase dysphoria, agitation, behavioral disinhibition, which essentially can numb the fear of death that might otherwise act as a barrier for suicide behaviors or completion. And then on the other side of the coin, we have withdrawal, which has its own dangers. Withdrawal often intensifies depression and anxiety and creates this acute window of vulnerability. In things like opioid use disorder, there's this cycle of kind of negative reinforcement where people are using to avoid physiological, psychological, psychic pain. and then make an attempt at abstinence to extract themselves from the pain that might be associated with the substance use itself, which then results in withdrawal, becoming a risk factor again. And again, when distress escalates, suicide can feel like the only way out for some individuals. Next slide. We also see some neurobiological mechanisms that can help explain why there's this overlap or why suicide and substance use risks are so tightly linked. First, with serotonin, impaired serotonin function increases vulnerability to things like depression and impulsivity, risky behaviors. This makes people more predisposed to misuse substances, more likely to act on suicidal thoughts. And then substances like alcohol and stimulants, etc., further disrupt those serotonin pathways, which weakens mood regulation and impulse control, which again elevates suicide risk. Second, we see that in the prefrontal cortex, which is the brain's decision-making and self-control center, some people naturally have lower gray matter volume here, which can make it harder to weigh consequences or resist urges, which raises the risk for both substance use and suicidal behavior. And then if there is substance use over time, chronic use can shrink that gray matter. And suicide risk is higher when the prefrontal cortex is underactive because people are less able to pause and reflect and access coping strategies in moments of crisis. And then third, we have kappa receptors. When the kappa system is overactive, it creates a baseline of dysphoria and hopelessness that which can predispose someone to use substances for relief. And it also creates the suicide risk when distress spikes. Substance use and withdrawal then activate kappa receptors even more, which can fuel despair and anhedonia, which are states often seen before suicide attempts. Next slide.
And just changing gears just for a second, I'm going to spend a little bit of time talking about harm reduction. Just, I guess, a general heads up. I'm going to define harm reduction in two ways. And the first way that I'm going to define it is going to be rather broad. And I want it to be as broad as possible with the understanding that not everybody views it necessarily as such. This is simply my effort at further destigmatizing the phrase by also showing how much of our everyday work falls under the scope of practice. In which case, harm reduction refers to the intentional practices and public health policies that lessen negative social or physical consequences associated with everyday human behaviors, whether those behaviors are legal or illegal. And under such a broad scope of practice, almost anything could be considered harm reduction or risk management. So this is use of seatbelts, this is helmets, this is proper application of sunscreen, this is encouraging medication adherence, maintaining a healthy diet and exercise, using condoms, dental dams, things of that nature. It can be literally anything. But I think that it would also be very remiss of me to not acknowledge that most of us have come to know and understand harm reduction in the context of substance use, whether that early exposure was decades ago in the 1980s or whether that is currently through the height and the continuation of the opioid epidemic. In which case, our definition of harm reduction has to shrink just a little bit to include the specifics, in which case it begins to refer to policies, programs, and practices that aim to minimize the negative health and social and legal impacts associated with drug use, drug policies, and drug laws. But it also protects the life, the health, and the dignity of the people who are using drugs as well as their communities. Also as like a small quick aside, this more traditional definition of harm reduction includes alcohol and sex work. You just kind of plug for X and the definition changes just a little bit. And we do have a framework for implementation, and we like to use SAMHSA's 2023 harm reduction framework. It outlines 6 pillars and a handful of core practice areas that harm reduction should include in order to be the most impactful. So, harm reduction should be led by people who use drugs and have the lived experience of using substances. It embraces the inherent value of people. It commits to deep engagement and community building. It promotes equity, rights, and reparative social justice. It offers the most accessible and non coercive option available, and it focuses on any positive change as it is defined by the individual. And we further the mission outlined by the 6 pillars by centering our focus on a couple of core practice areas, which expands to include access to safer practices, safer settings, safer access to healthcare, safer transitions to care, creating and maintaining a sustainable workforce and field, and creating sustainable infrastructure so that we can maintain the work that we do. And I think that this should all look really familiar to everybody because it overlaps significantly with identified protective factors in suicide prevention. So, this is access to behavioral health care. This emphasizes connectedness to family, community, and other social institutions. This is access to life skills. It centers on giving patients and clients a sense of purpose and meaning in their lives, and it is sensitive to and aware of the importance of cultural, religious, and personal beliefs and as motivations to change. So, almost most importantly, the framework emphasizes that we're meeting people where they are and we're not leaving them there. There are a couple of different strategies of harm reduction in substance use that also happen to address suicide risk. Just a bit of a heads up. This is a little bit of a longer one because that first bullet point there, harm reduction education, expands to include pretty much all of the other bullet points that are listed here. So, in regards to education, I do want to start off by saying that it's not simply about educating the client or the patient. This also includes the education of family members, especially those that are living in the home, regarding the lethality of substances, especially if those substances are opioids. This holds true for both prescription medications that have the potential for misuse, as well as anyone who is accessing a more illicit drug supply. In the case of opioids, access to naloxone becomes a major protective factor, regardless of whether or not it is intentional or unintentional overdose risk. And I do want to emphasize that last statement, intentional or unintentional, because when fatal overdoses occur, we cannot always make the assumption that an individual encountered a potent batch. That's not to say that potency is not a concern in the illicit supply. It most definitely is, and we have seen that the last 5 to 10 years. Um, but I think that it's also important to keep in mind that some of the communities that we're seeing an increase in overdose fatality includes Indigenous peoples and Black men, both of which have already high or increasing rates of suicidality. But there are other demographics that also have a similar overlap in risk that includes LGBTQ youth, people in rural communities, people who are coming from low income and low education backgrounds, as well as veterans. Also, education here includes having conversations about polysubstance use, especially where mixing prescription medications or even just illicit substances that people are consuming with alcohol. From here, there are a couple of other touch points, such as safe prescribing and encouraging safe storage. In this particular context, safe storage would be lethal means restriction, but we should also be encouraging safe disposal as well, and including avenues in which um, they can dispose of medications when they need to, or dispose of any other substances when they need to, regardless of what that need may be. Um, Also, we should be advocating for MAT, medicated assisted treatment, or MOUD, medications for opioid use disorder, where we're able. And as a quick aside, as educators, we too should my apologies. We too should really be considering harm reduction education for ourselves because as the illicit supply is changing, we're seeing less fentanyl in samples and an increase in sedatives like xylazine and medetomidine, in which case access to traditional drug checking measures like fentanyl test strips will not work. Naloxone will not work in this case. And if there is a situation where a person may know that there is xylazine or medetomidine in their substances, and they are using with the intent that naloxone cannot be used to reverse this incident, that's really concerning. And so it never hurts to be aware of what the drug trends are looking like in our state. Moving on to drug checking. I think it goes without saying that in April of 2023, fentanyl test strips were decriminalized. Xylazine test strips at this current moment are still considered drug paraphernalia, but we're looking to see that it's going to join fentanyl test strips in legality. Where possible, other drug checking services should be promoted, and this provides a more comprehensive look at all components of the substance that is being used and allows for the individual to modify their use or at least change the environment in which they're using in. I will say that hotlines like Never Use Alone and 988 don't necessarily address both substance use and suicide risk at one time, but hotlines themselves address hallmarks of successful intervention such as social connectedness and belonging, which are both critical to address substance use risk and suicide risk. And lastly, the first pillar on SAMHSA's harm reduction framework is that harm reduction should include people who use drugs. And at all avenues, we want to be centering the voices of people who know what this experience looks like by encouraging individuals to meet with peer supports and to get in touch with peer recovery community organizations. So I know that was a lot. I have two other slides relating to harm reduction, and I think that it's pretty interesting. So this image here on the far left is of a harm reduction vending machine that's in Cuyahoga County specifically. And we have a lot of really rich harm reduction in place. Ohio is surprisingly really ahead of the rest of the United States. It's really, really cool stuff. But the numbers of how many different harm reduction avenues there are, I only have from 2024, so there could be more or fewer services available than what I have listed, but we have 27 naloxone vending machines across 20 counties, 281 emergency nalox boxes and cabinets across 34 counties. I think we have like close to 300 or 400 Project Dawn locations across 84 counties, but that could have expanded to include all 88 at this point. We also have, I want to say, between 40 to 44 syringe service programs across 25 counties, so it's not the most available service at this time, but I see that changing. And I also wanted to include a couple of graphics here. These are tools that were created by Hamilton County Public Health. And I wanted to show these because they're all materials that blend into the settings that they're displayed in. And so this is incredibly accessible. It doesn't need to stand out in any particular environment and like draw attention. It's so everyday that anyone can include it. So on the left, this is a drug checking. It's like a card that's inside of a drug checking kit. And so it asks for the method that a sample was taken, a description of the substance, what it looked like, the location that the substance was obtained, sensation or experience of taking said substance, and then participants who want their drugs tested then receive the results 2 weeks later. So it gives them a lot of agency in choosing how they would like to use and if they would like to continue use or whether or not they would like to get on MOUD moving forward. There in the center are discrete fentanyl test strip labels for boxes that have been dropped down in Hamilton County's community. And there on the right is a graphic that was created for a nightclub. It was made to blend into the background of a bathroom so that if you're looking for it and you know where it is, then you're able to access it. But The placements of boxes and the test strips in the community were all data driven. Their epi team looked at areas with high rates of overdose, and they coordinated with different organizations and businesses to place boxes with OD reversal or testing tools. So again, it includes nightclubs, but it also includes family-friendly breweries and barbershops. Passing it back to you, Ashley.
Thank you. So, why use harm reduction and integrated care? I think that, as you can see here, they share a lot of the same values. They're person-centered, so rooted in dignity and respect for individuals, putting the person, not the diagnosis or the disease, at the center. There's a whole person perspective, so we see health in context, not in isolation, and aim for continuous and coordinated care, recognizing that when care is fragmented, people fall through the cracks, risk increases then. The patient is informed and empowered. So people are active partners, not passive recipients. Respect and empathy are emphasized, so people feel safe enough to engage. Both strive to make care accessible and remove obstacles, and they're evidence-based. They save lives, improve outcomes, keep people connected to services. Next slide, please. So this comes from an article that's linked in the references. Like I said, we could talk about this subject forever, and I didn't want to take this slide out, but this is from a paper that talks about harm reduction practices integrated into medical care, that you guys can take a look at on your own. Next slide. So when we think about what every integrated care team can do, there's some straightforward practices that make a big difference. Screening for both suicide and substance use should be routine, just like if we were screening for blood pressure, diabetes. We want to normalize harm reduction by treating it like any other prevention strategy: seatbelts, sunscreen, vaccines, medication practices, and that everyday framing helps reduce stigma. Making naloxone available and teaching patients and families how they can use it should be a standard of care. And just like we create safety plans for suicide risk, we can incorporate overdose safety planning into those treatment discussions. Sharing crisis resources like 988 or Never Use Alone allows people to reach for something when things get difficult. And finally, none of this happens in isolation. Collaboration across medical providers, behavioral health, peers, community services makes the care truly integrated. Next slide, please. And once the basics are in place, if individuals or agencies want to go further, there's other tangible ways. It could mean offering or partnering to provide MAT or MOUD so treatment is truly accessible. It might look like increasing access to medication or supplies at your site, like installing a nalox box or a harm reduction vending machine with harm reduction supplies. It means delivering comprehensive medical care, making sure HIV and hepatitis C screening and treatment is happening, that you are able to provide prevention like PrEP and PEP, regardless of whether someone is in substance use treatment or their recovery status. Expanding knowledge across staff is important too. Like Amari has referenced, harm reduction isn't just about opioids. It covers a wide range of substances and behaviors. Building stronger connections with local harm reduction programs creates this opportunity for resource sharing and learning. And then finally, knowing your deflection teams and building relationships with them can open doors for referral and support. Next slide.
So I guess like the whole purpose of this is that we're already doing the work. There are already strategies in place, and specifically, a majority of the protective factors identified and addressing suicide risk can also very, very easily apply to addressing substance use. Also, we're already taking care of being mindful of the overlapping demographics. Like I said, rural communities, Black men, Indigenous people, queer youth, people from low income or low education backgrounds are all at risk from both um, suicide risk and substance use risk. And so it's already there and it's ripe for the taking.
And driving home this idea that harm reduction is suicide prevention, and Mari has talked about this, that harm reduction pillars really align with these protective factors for suicide and substance use. They share many of the same protective factors. And also to care is to reduce suffering. Even when healing isn't completely possible yet, keeping someone alive and connected creates space for recovery and hope. Next slide. So we wanted to make sure that you guys had some tangible resources as well. So we've included a slide that has patient facing resources that includes where you can get naloxone, fentanyl test strips, PrEP, syringe services, and mail order syringes, etc. Next slide. And some practice or provider facing resources. There's toolkits on here, implementation guides. There's an upcoming webinar, I think it's next week, specific to the intersection of alcohol, depression, and suicide. So we wanted to make sure that y'all had these things. And I just want to end with a quote from Dr. Gabor Mate, who's one of my favorite people to speak on addiction. He says harm reduction is often perceived as being inimical to ultimate purpose of curing addiction. That is, of helping addicts transcend their habits and to heal. People regard it as coddling addicts, as enabling them to continue their destructive ways. It's also considered to be the opposite of abstinence, which many regard as the only legitimate goal of addiction treatment. Such distinctions are artificial. The issue in medical practice is always how to best help a patient. If a cure is possible and probable without doing greater harm, the cure is the objective. But when it isn't, and in most chronic medical conditions, cure is not the expected outcome, the physician's role is to help the patient with the symptoms and to reduce the harm done by the disease process. In other words, harm reduction means making the lives of afflicted human beings more bearable, more worth living. And the last slide is just our references.